Hello, everybody. My name's Ed Pavlik. I'm going to give you another GYN ONC Garage from Lexington, Kentucky, where a heat dome has been sitting on us for about a week. The weather's in the 90s. It's pretty darn warm. My colleague today is,
Frank Lawton. Whoa, sorry, Ed. Frank Lawton from London, UK. It has been very, very warm here as well in the low 80s, but the weather has broken. It's now becoming quite gloomy in places and has been raining quite heavily for the last 2 or 3 days. But the garden likes it. It means I don't have to get up in the morning and do watering of the various flower beds and things. But I'm sure we have another heat wave coming, I think, in the next week or so. We get one of these every decade or so when it's very, very warm, and you know what the English are like about the weather. So we complain it's too hot, then we complain it's too cold, then we complain it's too wet, then we complain it's not wet enough. So
well, I'll tell
when
you,
you live on a small island in front in the middle of the Atlantic or at the end of the Atlantic, this is what happens. This is weather. This is not climate. This is weather.
I'll tell you about something that's really hot, and that seems to me to be the Lionesses, which they're plus playing about it as hot as you can, coming from behind and all. Uh,
Uh,
the final on Sunday in Basel, should be a wonderful match. What do you think about the Lionesses?
Absolutely. They certainly are a heck of a lot better than the England men's team, although they have done quite well in international matches recently. But I think they've really produced the goods, haven't they? They're coming from behind 2 or 3 times, or scoring after extra time, or on penalties, which is the England men's team have always had a problem with losing on penalties. Obviously, they're up against a pretty strong team, though, who've got a very good record. But they've won it before, so it might happen again. I'll be in, or my wife and I will be in Norway, northern Norway at the time. So I don't even know whether they have television this far north of the Arctic Circle we're going. But if they do, we'll be in the bar watching the football.
Okay, well, that sounds like fun to me. Um, Today, we're going to consider the question, do neck lymphatic metastases in advanced epithelial ovarian cancer respond to chemotherapy? And the answer to this question is approached in the paper titled Clinical Efficacy, Analysis of Chemotherapy of Isolated Neck Lymphatic Metastases in Advanced Epithelial Ovarian Cancer, which was recently published in BMC Cancer Journal. This work investigates if chemotherapy has any effect on neck lymph node metastasis in stage 4 ovarian cancer. Frank, what's your spin on this? Give us your insights.
Okay, well, I've always, not just me, I think there's always been a problem with the FIGO staging of anything more than stage 3 disease. It's almost like FIGO has said, well, anything that is outside of the peritoneal cavity, including the liver, um, the prognosis is so poor that we can put them all together. So whether or not you've got liver metastases or groin nodes or brain metastases or bony mets, they shove them all together into this stage 4. Stage 4A, which is essentially liver mets, and stage 4B, everything else. And there's no doubt that there's a difference in survival. And there was a paper from the Dutch group, some years ago, looking at a 5-year survival for 4A, which was about 9%, and 4B, which was 13%. So the staging itself seems to be lacking. It's wanting something, and I think this group has tried to show whether or not that there are certain subgroups of 4 disease, and they've chosen supraclavicular neck nodes as their parameter of response. They One of the problems I think is that they've said these are isolated neck nodes, and there's no evidence in the paper as to whether or not the nodes on pre-operative imaging along the paraortic chain or wherever else were positive as well. They've said they've done a lymphadenectomy in certain patients, but they haven't actually said the number of patients that had positive neck nodes, how many of them had positive paraortic or pelvic or anything other nodes. Um, the I think another problem is that the numbers are tiny. I think they've been following these, or they've recruited these patients over about 10 years, and they've only managed to find 24 patients. So 3 a year is it's never going to have the power that we need to actually say this is been resolved. So they've used criteria which are called, and I've written it down somewhere, response evaluation criteria in solid tumors, to determine whether or not the lymph nodes are of significance. And one of the parameters is that the nodes have got to be at least 1.5 centimeters longest diameter in order to be not to be significant, but not target lesions. And out of these 24 patients, 17 of them had nodes diameters of less than or equal to 2 centimeters. So again, I'm not sure how many of them would actually meet the criteria of being significant nodes from the point of view of monitoring. So they found these nodes, did fine needle aspirate, found them to be positive, and then the majority of these patients had neoadjuvant chemotherapy and intervention surgery. And the intervention surgery that they carried out was quite extensive, as you expect, in order to try to get an R0, no intra-abdominal macroscopic disease, hysterectomy, BSO, bowel resection, diaphragmatic resections, pelvic and paraaortic nodes. So they've had quite extensive surgery. But unfortunately, because the pathology is not being reported as the pathology, we don't actually know whether or not there was a response in the pelvic nodes, a pathological response since they removed them, as opposed to a radiological response. So did these patients who had a response in their neck nodes have a similar response in their pelvic nodes? And I think that'd be quite important. Are pelvic nodes different? The spread to pelvic nodes different from the spread into the paraortic or the supraclavicular region? That having been said, they got a 33% complete remission rate, they say, 62% partial remission, but I don't know whether that is radiological or clinical. But that's sort of the numbers that you'd expect, I suppose, for IDS and radical debulking. Interestingly, the recurrence, only two of the recurrence were in the nodal region. The majority of recurrences, 13 out of 15, were in the abdomen, pleura, brain, which is a very unusual place for recurrence, or bone. So is there something unusual about this group of patients that although there seems to be response in the neck nodes, the majority of patients still, when they recur within the pelvic cavity. Overall survival is probably as well as you'd expect, 16 months. Uh, Progression-free survival for lymph node negative. The other patients, univariate analysis, progression-free survival and R0 are the only two of significance from the point of view of PFS, and for OS, for overall survival, recurrence and site of recurrence. So I think the conclusion is that patients who have small volume disease at the end of surgery, and obviously nodal disease less than 2 centimeters, even if you leave it behind, is small volume, that would count probably as R0 or R1. So if you have a small volume disease at the end of surgery, regardless of whether you've got supraclavicular nodes, the outcome is probably quite good. The majority of the recurrences, despite there being disease in the supraclavicular region, are in the abdomen. And I think the final thing is that, as I said at the beginning, the FIGO classification of FIGO 4 disease is too vague. There's something else going on. Is disease outside of the peritoneal cavity, but not in the liver, a different sort of disease than disease where there are liver metastases? And certainly the Dutch group that I alluded to at the beginning did suggest that they were two slightly different pathologies. And I think this paper suggests that that might be the case, but I think the numbers are so small and the confidence intervals are so broad that it's really difficult to say. I think that nodes are not a place of chemo resistance, which has been thought in the past. And certainly in some diseases like breast and pancreas, nodes are thought to be an area of chemo resistance. But it seems to be in epithelial ovarian cancers that distant nodes are chemosensitive. They do respond to chemotherapy, but probably in the end, when the patient relapses, they are not the site of relapse.
Yeah, I agree with you. I mean, I think the reader has to be impressed with the fact that these were nodes that were left in place. And then they were observed for how chemotherapy affected them. And it is pretty dramatic in this very small data set uh, that the neck nodes pretty much were sensitive to chemotherapy, except for 2 out of 15. So, I mean, it leaves you with sort of a conundrum in a study that's hard to do, where you can't scrape together the numbers that easily, if at all. Um, what should be the reviewer and the editor's position? And in this case, it was to go ahead and publish it and let us, have a taste of what seems to be happening here.
Yes, I think that's a very good point. As a gynecological oncologist, I think if we'd found positive supraclavicular nodes, we certainly wouldn't have tried to excise them. I don't think that's the role, certainly not in the UK. That is not the role of gynecological oncologists. And I think what we would have probably done is given radiotherapy rather than try to excise them. Radiotherapy to the neck obviously has side effects. Most patients who've got disease outside of the abdomen are going to get chemotherapy anyway. And I think this study does suggest that you're not actually doing the patient a disservice by not dissecting or irradiating the supraclavicular area. The chemotherapy will sterilize that area just as well as it does in any other nodal area. But the numbers are small, and I don't think we can be sure about that. But I think this paper would suggest to me anyway that radical neck surgery is not necessarily necessary in stage 4B ovarian cancer. In fact, it's
Sure.
probably contraindicated, in fact, perhaps.
And it opens the door for someone to say, well, what are the risks? And the answer would be, well, in the case of a recurrence in the neck nodes, you have the possibility of palpating it physically and seeing if it's turning hard, or sampling it by, with a needle. And
Absolutely.
and
Yeah.
so, I mean, you're not exactly hanging somebody out to dry if you leave those nodes behind.
Sure. And you could probably, should their disease occur in the supraclavicular area, you could probably could irradiate them. There is a salvage role for radiotherapy in extra ovarian disease, which has been shown for many years. And I think I think this reduces the potential radicality of some gynecological cancer surgeons who say we should go all out to remove all evidence of disease wherever it is in the body. I think this shows that you don't need to be that radical. You can stick within the abdomen and the pelvis and possibly the pleura and the diaphragm, but you don't need to go up here.
Absolutely. Well, let's put this one to rest and say we'll see each other in a month. I
We
think
will indeed.
you're off to the Arctic, so
Up to the Arctic, yes. Yeah. 3 weeks of looking at. I say to my colleagues that we're going to look at penguins, but of course, then they say, Frank, there aren't any penguins in the Arctic. And I know that I'm being postmodernist. It's polar bears we're looking for.
I see. Well, don't put your tongue on any steel poles or anything like
No,
that.
I won't. No, I'll be very careful.
Okay, very good, Frank. We'll see you in a month.
Okay. See you in a month.